So we've got a real special treat today. We've got my classmate from the accomplished and generous class of 1978 at Dartmouth College. That should be enough for you, but I'm going to give you the details. So it's Dr. Marco Zarbin, who received his BA in biochemistry from Dartmouth, where he was Phi Beta Kappa, summa cum laude, with highest distinction in 1978. He's taken better care of himself than I have. He later attended Johns Hopkins and was awarded degrees in medicine and pharmacology, and graduated as a member of the Alpha Omega Alpha Honor Society. Dr. Zarbin did his residency also at Johns Hopkins, completing fellowships in vitreoretinal surgery and in medical retinal disease. Dr. Zarbin served as an assistant professor of ophthalmology at the University of California in San Francisco, and as chief of the division of ophthalmology at the Department of Veterans Affairs, also in San Francisco. He was appointed chair of the Institute, again, of Ophthalmology and Visual Science at Rutgers, our state university, and chief ophthalmology at University Hospital in Newark. He has the Alphonse O. Snothy, MD, Lions Eye Research Professor of Ophthalmology and Neuroscience, also there. He's co-director of the Ocular Cell Transplantation Laboratory at Rutgers. His research is focused on surgical treatments for age-related macular degeneration, which is, the leading cause of blindness in persons over age 55 in the United States, if you know anyone like that. Yeah. This research, which involves the transplantation of specialized cells, has been supported by grants from numerous foundations. He's also written extensively in the field. He's past president of the Board of Trustees of the Association of University Professors of Ophthalmology, editor-in-chief of Translation, Vision, Science, and Technology, and a member of the editorial boards of Ophthalmology and the Asia Pacific Journal of Ophthalmology. He's received so many awards, I can't list them all here, but they include the Life Achievement Honor Award from the American Academy of Ophthalmology, and he's received an honor award from the American Society of Retina Specialists. He has been listed among the best doctors in the New York area since 1996. Without further ado, I present to you Dr. Marco Zarbin.
Thank you really for a very generous introduction, Jerry. I want to ask two questions before I get started. First, how many of you here know someone who's getting treated for age-related macular degeneration? A lot. Okay, that's what I expect. Second question, how many of you have a background in biology? One, two, and I know you do too. So that determines whether I'm going to show a particular slide or not. But my sense is that we have a very strongly educated group of people here. So if you give me a minute, there's a slide that I wasn't going to show that I'm now going to turn on because you might find it interesting. And then I'll start the talk. And the talk is about 55 minutes. And so I think that will leave time for questions, should you have any. Bear with me, please, for a moment. So today I'm going to talk about age-related macular degeneration, its pathogenesis and therapy. And these are my financial disclosures, all of which are relevant in some way or another to the talk. But in fact, they're only relevant in principle, but not in reality. I'm going to first describe for you the ocular anatomy because I think you can't really understand the stages of the disease and certainly can't understand the basis of the treatment for the disease without understanding the anatomy. And that'll be pretty straightforward. And then I'm going to define the disease and show you the clinical manifestations, many of which you've probably heard of, but you may not actually know what those manifestations are in fact. And that sets up an explanation for the pathogenesis, which in turn is the basis for the therapy. And that is also the basis for understanding what the therapies in development are based on. So first, the anatomy. And now the external anatomy of the eye is familiar to everybody. The white part of the eye is the sclera. Then the clear part of the eye is the cornea. The colored part of the eye is the iris, and then that hole in the iris is called the pupil. Now, this is obviously the eye in the orbital socket, looking from the side. And if we were to cut the eye in half, you'd see this cross-sectional image. And what I want to focus on now is the cross-sectional image of the eyeball itself. And here you can see the clear front part, the cornea, behind which is the lens. And as you probably know, the cornea and the lens are important for focusing light on the retina. Then you have this clear gelatinous material called the vitreous, which occupies about 4/5 of the volume of the globe. And then the next thing we'll encounter is the retina, which is the actual neural tissue in the eye. And that contains the light sensing cells that convert electromagnetic energy to electrochemical energy. And then because of processing that occurs in the retina, we convert that into a series of on-off signals. And I think there are a number of engineers in the room, so that'll kind of make sense to you. Now, external to the retina is a vascular layer called the choroid. This is a little bit counterintuitive, but it turns out that the retina has two sources of blood flow. One which is shown well here, which is the external source called the choroid. It supplies the outer 1/3 of the retina. And another which isn't shown well in this picture. Let's see if my cursor shows up here. It does. But it's an inner layer of vessels called the retinal blood vessels. And then external to the choroid is the white part of the eye, which is the sclera, which is essentially sinew that protects the internal structures. And then these on-off signals that are generated through image processing leave the retina and the eye through a structure called the optic nerve. And from there it goes to various nuclei in our central nervous system. But the retina is part of the central nervous system. So this is actually a picture of a cadaver eye, obviously a human cadaver eye, and you can see the lens and you can see the retina. And then there's this area in between the two, which doesn't contain any neural tissue, called the pars plana. And it's through that area, for any of you who get injections or who know people who get the injections in their eye, the needle goes through the pars plana so that it won't damage the lens or the retina. And if any of you by chance have received a sustained delivery system, that's also implanted through the pars plana. Okay, now the retina lines the inner 2/3 of the eyeball, but the part of the retina that subserves very high acuity vision comprises a very small fraction of the total surface area, and that's called the macula. And I'm going to show you what this looks like clinically in a fundus photograph. So this is a picture of the back of the eye, focusing on the macula, but just so for clarity, you can see this rather thin retinal artery, a thicker retinal vein. This is what the optic nerve looks like when you look at it on FOSS. And then there's the macula, which is a specialized region of the retina. But the most important part of the macula is the very center, and that's the fovea. The fovea is the part of the eye that creates high acuity vision, which we use to recognize faces, to read, to thread a needle, to do surgery. If you shoot sporting clays, when you're looking at that clay, that bird, that's what you're looking with, the fovea. And to understand, to have a deep understanding of what I'm about to talk about, we need to look at the structure of the fovea at the level of resolution of light microscopy. So that's what I'm going to show you now, which is to orient you. The neural tissue is shown the retina. And you'll notice that the retina has these purple dots. These are different layers of cells. And the layer of cells that we're going to be focusing on are the photoreceptors. Then the layer external to the retina, as I mentioned to you before, is the choroid. It's a vascular layer, which supplies the outer third of the retina. And then you can see the sclera. But I'm showing you this picture to show you the retina. And you can see the macula. is a much larger surface area. In fact, this slide inaccurately demonstrates the full extent of the macula, but it's a much larger surface area than the surface area of the fovea. And just by looking at this picture, you can see what's special about the fovea. There are no cells in front of the photoreceptors. And so in the very center of the fovea, the photoreceptors are highly specialized. They're a type of photoreceptor called cones, which in fact, they're specialized cones. And they are what we use to see well in conditions of bright light. Whereas if we move off to the side, away from the foveal center, we have rod's end cones. And of course, as you know, rods help us in conditions of dim illumination to see. Now, the next slide I'm showing to illustrate the relationship between location in the retina and visual acuity. So to remind you, we have the cones, dead center. And on the left is a plot. It's a plot of visual acuity on the y-axis is a function of location on the x-axis. And the 0-degree location is the fovea. And so I've shown you the corresponding regions with the red arrows. And that almost discontinuous peak in the fovea in terms of visual acuity, that's dead center. So the point here is that as you move away from the foveal center, visual acuity drops off exponentially. And that's why you could have damage to just a 250 micron region of your retina. But if it involves the fovea, your vision is going to decrease from 20/20 to 2200 or 2400, which is the level of blindness. Now, underneath the photoreceptors is a layer of tissue called the retinal pigment epithelium. And it's a pigmented layer of cells that I'm going to show you in schematic form in the next slide. So the RPE cells are cuboidal, they contain pigment, and their function is essentially to nourish the photoreceptors. And they reside on a surface of connective tissue called Bruch's membrane. Now, just to remind you, external to the RPE and the Bruch's membrane is the choroid, which is a vascular layer that supplies the blood flow to the RPE and the photoreceptors. Now, it is a remarkable fact that we can image the retina in a living patient at the level of resolution of light microscopy. And it's a very important fact. Otherwise, we wouldn't be able to do the treatment for the wet form of macular degeneration properly. So on the top, I'm showing you the histology of the fovea. And on the bottom, an image of a different patient, obviously, because this patient on the bottom is alive, whereas the one on the top is dead. But it's an image that's created with a technology known as optical coherence tomography, which essentially is taking advantage of the different refractive properties of different layers of the retina. And you shoot in a long wavelength light, you get a pattern, a diffraction pattern back, and then you can actually reconstruct the different layers that way mathematically. But just to give you a sense of the resolution of the system, you see the foveal photoreceptors pointed out with a red arrow. Those photoreceptors are evident in the red arrow in the OCT image. There's a part of the photoreceptor that's very enriched in mitochondria called the ellipsoid, which you can see in the histology. And you can see that layer in this picture. It's that bright band. And then there's a part of the retinal pigment epithelium, which is that pigmented layer in the picture. And you can see that band, which is a second bright band in the OCT image. So this works trivially at the level of resolution of 3 microns. So you can even with certain refinements get higher level resolution. So I haven't told you how we see, and that's not the purpose of this talk, but it seems like it's appropriate, at least in a very superficial way, to explain it, at least as far as I understand it. So you have light reflected off an object externally. That light gets focused by the cornea and the lens into a real inverted image on the surface of your retina. And then, of course, that electromagnetic energy is what excites the photoreceptors to generate this electrochemical signal, which is the graded action. It leads to a change in the membrane potential of the second order neuron. And this is where the magic happens. that image gets deconstructed in various ways. It gets deconstructed with regard to edges, rate of movement of edges, contrast, color. It's like taking apart a sentence, if you ever had to do that when you were in grammar school. And that deconstruction is essentially a series of ones and zeros that leaves your eye through the optic nerve and goes into the brain. And it first goes to the lateral geniculate nucleus, which is about here, deep, and then to the back, to the striate cortex and the occipital region. And then the whole thing gets reassembled through the parietal cortex and the temporal parietal cortex. And it's somewhere here in our brain, inside my skull, about this level, that we actually see. Seeing does not happen in the retina. Okay. So now for age-related macular degeneration. So, first I'm going to define it, and maybe it won't make any sense to you. And then I'm going to show you what I mean, and then I'm going to show you the definition again. So hopefully that will make you feel like you've learned something. So it's a condition that's characterized by the accumulation of abnormal debris, actually membranous debris, external to the retinal pigment epithelium. And the clinical manifestations of the disease are drusen, atrophy, which is death or degeneration of the photoreceptors, the retinal pigment epithelium, and the choriocapillaris, detachment of the retinal pigment epithelium from Bruch's membrane, and then choroidal new vessel formation, which you probably know as wet AMD. And this typically onset after age 50. As Jody mentioned, it's still the major cause of blindness in persons over age 55 in the industrialized world. Prevalence of about 18%. So 1 in 5 people. That's why I was pretty certain that just about everyone here would know someone that had the disease or actually has it themselves. Now, what are drusen? They are the hallmark of the early and intermediate stages of the disease. What do they look like? Well, that's shown in this picture. They look like these yellow spots under the retina, and we can image what they look like using the OCT machine, and that's shown in panel D of this photograph. You can see how that hyperreflective RP band is elevated off of the Bruch's membrane surface. And that material that's elevating it is the drusenoid material. And to show you what it really looks like, I'm going to compare the histology with an OCT image. So histologically, you can see the photoreceptors. The little purple circles are the cell bodies, and the areas here, I guess I need to move this. This area is the finger-like, like the teeth of a comb that project from the cell bodies to the photoreceptors. And that part of the retina is known as the outer segment of the photoreceptors, and that's where the light capture, the photon capture occurs. And with this level of magnification of the OCT, you can't really see the photoreceptors with that level of detail, although you did in the previous image that I showed you. Then we have the retinal pigment epithelium, which is evident in the OCT image as that hyperreflective band. And then you have the abnormal debris underneath the retinal pigment epithelium, which is very easy to see in this quite large druse. Normally they're not this large, but it makes for a nice illustration. Now, in the late stages of the disease, I've showed you the early intermediate stage. What do the late stages look like? Well, there are two different manifestations. One, probably you know, is wet AMD, which is actually choroidal new vessel growth under the retina. And that's shown here, where you have a choroidal new vessel. And the problem with these things is they create scar tissue, and they bleed and leak fluid. And then the other type of manifestation known as dry AMD, which is very misleading terminology, we call geographic atrophy technically. And in geographic atrophy, you see this clearly abnormal area, although you may not be able to articulate what's abnormal about it. But if you look outside the area of atrophy, you see that sort of sunset glow orange. that color is due to the pigment in the retinal pigment epithelium. So in the area of atrophy where you're missing that color, it's because the RPE cells have died. Not only that, I don't think you need a degree in biology to see that you're looking at larger vessels in that area. What are those? Those are the larger choroidal vessels. Why can you see them? You can see them for two reasons. First, because the RPE cells are dead and gone. And second, because the choriocapillaris, which are capillaries, have atrophied, leaving behind only the perfused larger vessels. And so a simple-minded way of thinking about wet AMD is that you have the presence of abnormal tissue that causes blindness. And in advanced dry AMD, you have the absence of normal tissue that causes blindness. How do you get one versus the other? We're going to talk about that. Now, here's a patient who has wet AMD, and I've actually shown you something similar, but let me show you how we image such a patient, how we visualize the abnormal vessels. The traditional way is to inject a dye called fluorescein into an arm vein and take pictures of the back of the eye. And this dye fluoresces. And so with the right filters, you can capture the emitted fluorescent energy. And the dye tends to accumulate in the abnormal vessels, which makes the abnormal vessels look bright. But we don't need to do that in many, many cases. In most cases, all we need to do is an OCT image. And what we'll see with an OCT image is that elevation of the RPE cells, but the material elevating it has a higher optical density than drusen. And so we can usually identify the choroidal vessels that way. Now, we can similarly image the presence of atrophy. Now, on the left is a normal fovea, and that bracket showing the thickness of the photoreceptor layer of the fovea. But in a person who's got advanced dry AMD, which is shown on the right, you can see there's virtually no photoreceptors left. So this is how we actually examine the patients to figure out what to do for them. Now, there's this sort of mythology that seems to have arisen, which is that you either have the wet AMD or the advanced dry AMD, and that's simply not true. And in fact, if you look histologically, about a third of the patients have both conditions. Here's a patient who is an example of having both conditions. This person has drusen, those yellow spots. The person has atrophy, where you can see through the pigment epithelium. And they also have a choroidal vessel. Now, how do I know that? Because that little red spot is a hemorrhage, and that's usually a sign of a choroidal vessel. So these things can coexist. So now I'm going to show you the definition again. It's characterized by the accumulation of membranous material under the retinal pigment epithelium. The clinical manifestations are drusen, atrophy of the photoreceptors, RP and choriocapillaris, RP detachment, choroidal vessel formation. Hopefully you now know what each of those things mean. Now, the real question is, why does all this happen? And there are competing theories about this. I think the simplest, Newton's law of gravity works pretty well. You don't need to use general relativity to do most calculations. That kind of simplification is what I'm going to apply here. I'm going to simplify the pathogenesis in a way that basically works pretty well by saying inflammation, uncontrolled inflammation, causes damage to the choriocapillaris and the retinal pigment epithelium, and that's what causes these changes. And when you get this chronic inflammation, you get damage to the choriocapillaris. And why is that important? The photoreceptors of the retina are actually they have the highest oxygen consumption of any tissue in your body. And in fact, for those of you with a biological background, you know that generally when you have oxygen present and they have a very high blood flow through the choroid, you create energy with oxidative phosphorylation. But in conditions of hypoxia, that is low oxygen level, you create energy using glycolysis. Well, the photoreceptors operate under conditions of aerobic glycolysis, which is shocking. It means they're always operating on the edge of hypoxia. So if you lose choriocapillaris from inflammation, you've immediately compromised RPE and photoreceptor function, and eventually could kill those cells. And you get abnormal blood vessel growth also when you have the choriocapillaris damage. I'm going to tell you a little bit more about that, although your intuition may already tell you why that happens. The way I think about the choroidal new blood vessel growth is it's what is called a homeostatic response. So homeostatic response, we could say, is a healing response. Naturally, when your body gets injured, it doesn't just sit there. You know, when you cut your finger, if you study it, you'll notice a couple of things happening. First, the margin of the incision gets pink. That's from the new blood vessel growth. Then it becomes irregular. That's because of contraction of the tissue that's actually filling in the wound. And then eventually, with good wound healing, you don't see the scar anymore. Although there are some people that have a lot of scarring, which are called keloids. Well, choroidal neovascularization is a homeostatic response to ischemia induced by choriocapillaris damage. And just to remind you, the retina has two sources of blood supply. The inner 2/3 is supplied by the retinal vessels, the outer 1/3 supplied by the choroidal vessels. And the choroidal vessels are the primary site of damage, in my opinion, in age-related macular degeneration. I want to show you why I think that using human histology. And to do that, I'm first going to show you what the architecture of the choriocapillaris is. It's a sinusoidal system. You know, it's not like input from artery to arterial to capillary to vein to vein. That's not how sinusoidal systems operate. It's arterial to a network of connected capillaries to venular to vein. So here is an electron micrograph of a choroidal lobule. And you can see the arteriole that feeds this cluster of connected choriocapillaries, and the blood flows from the arteriole through those vascular channels and then leaves through the venule. It's really pretty straightforward, but it's very helpful to have that image in your head. Now I'm going to show you the picture of an older person without AMD. So panel A over here is their clinical fundus photograph. Then they died, and you have these fundus photographs post-mortem. And you can remove the retina and image the choriocapillaries with a very special stain that makes them look red. And if you do that, what you'll see is the normal choriocapillaris under the fovea. And just to remind you, if you look at these little vascular channels, which are the capillaries, you can see them outlined with a red stain. That's normal. That's the way we all hope to look when we're 87. Okay, but now somebody who's not so lucky. This is an 86-year-old woman who had early age-related macular degeneration. It's the same sequence, her clinical photograph, her postmortem photograph, and now we're going to look in her macula at the choriocapillaries. And the first thing I'm sure you can all see is it's dark. It's dark because there's not much red stain. There's not much red stain because there is a great reduction in the choriocapillary density. And if you look under high magnification, that's very obvious because those asterisks that you see in the picture are areas where there are simply no choriocapillaries. And as I told you, when you're working in a condition of aberrant glycolysis, you can't afford to lose very many capillaries before you have a problem. Just to convince you that this is really a macular problem, if you look nearby, but not under the macula, the choriocapillaries are pretty normal. What's really interesting is that if you look at the edge of those areas of choriocapillary dropout, you see these areas of intense red staining. Those are shown under high magnification in the panel F over here. And what those are little buds of new blood vessels growing. And that's why I think that choroidal neovascularization is a homeostatic response to ischemia induced by choriocapillaris damage. Okay, let's look directly now at a patient that has a choroidal new vessel and see what that looks like. Well, I've shown you this patient already. This is the one with the fluorescein angiogram and the OCT image. And if you look, again, focusing on their capillaries using that red stain, you can see the choroidal new vessel. It almost looks like a sea fan, Gorgonia flabella, you know, one of those things you find in the Caribbean. And if you look under high magnification at the edge of the choroidal new vessel, that's what you'll see in panel F. And you can see that there's bright red staining where the choroidal new vessel is, and right outside of it, it's very dark, even with an asterisk showing there's no choriocapillaris. That's another sign that these things drive response to ischemia. And in contrast, if you look outside the macula, the choriocapillaris density as well. Okay, so the way I think we should think about choroidal neovascularization or wet AMD is that it's a pathologic vascular growth, but it's in response to inadequate choroidal blood flow. So we want the blood vessels to grow in response to ischemia, but these blood vessels are immature and they don't behave properly, and that's why they create a problem. And that's the basis for several therapies that I'm going to describe, is how to fix that immaturity. In the case of the geographic atrophy, let's see if I can get it to come up. There, the problem is the inadequate choriocapillaris blood flow causes death of the photoreceptors. In fact, what we should ask ourselves is, why doesn't everybody get choroidal neovascularization? And I don't know the answer to that question. Now, I haven't said why there's this inflammation in the choriocapillaris. And again, this is a matter of some controversy. I can tell you that highly metabolically active areas are going to generate reactive oxygen species. Reactive oxygen species are going to damage cellular structures, damage DNA, and that's cellular damage can create an inflammatory response. But that happens in all of us as we get older, and yet we don't all get age-related macular degeneration. I think the thing that leads in some people to getting the disease is what's called complement dysregulation. And I realize that most of you have not had a background in biology, so I'm going to take a minute here. The complement system it's the ancient basis of immunity in us. Okay, it's the first source of immunity as we evolved. And there are 4 different ways it can be activated. They're called the classical, the lectin, and the alternative pathway. And there's actually the 4th way, which I'm not illustrating, which is the extrinsic pathway. Now, as I mentioned to you, complement activation is really important for for our immune status. And it's so important that it's actually chronically activated, but we regulate it. And the reason it's chronically activated at a low level is that if some bacteria or virus invades us, you can get this massive acceleration of the complement activation system, really, really rapid. And it also helps our body clear the dead and damaged cells. Well, the problem arises when you have inappropriate activation of the complement system or dysregulation of the complement system. And actually, this problem is known to cause several different kinds of diseases. For example, there's a type of kidney disease called type 3 glomerulonephritis, which is due to inappropriate complement activation. There's a disease called paroxysmal nocturnal hemoglobinuria, which is associated with inappropriate complement activation. There's probably even some link to Alzheimer's disease in complement dysregulation. And as you might expect, I wouldn't be talking about this unless there have been documented mutations in patients with AMD in the complement regulatory system. And 1 or 2, all these green circles show areas where there are documented mutations in patients with AMD in the complement system. And so the thing from a pathway perspective, which is important for drug design, to understand is that no matter which pathway of activation activates the system, they all converge when this one molecule called C3. And when C3 is hydrolyzed or cleaved, shall we say, we form 2 components. One is C3A, which actually incites an additional inflammatory response, and one is C3B. And C3B hydrolyzes the second key component, which is C5, into 2 components. C5A, which also incites a massive inflammatory response, and C5B. And C5b combines with other components of the complement system to create what's called the membrane attack complex. But what it really is it's a pore. It's a pore in the cell membrane. And once you make enough of these pores, the cell can no longer regulate water passage into it, and it swells, ruptures, and dies. And when it's the bacterium cell, we like it. When it's our cell, we don't. Just to show you I'm not making this up, this is some histology of a patient with AMD. The red stain on the left is staining complement factor 5. You can see it's present in drusen. It's present in that abnormal material under the retinal pigment epithelium. And the membrane attack complex is present in RPE cells and also in drusen underneath the retinal pigment epithelium. And what you can't see quite as clearly is that both of these components are also present in the choriocapillaris. So I think this point may be subtle, but it may not be subtle to you. The current therapy for choroidal neovascularization actually doesn't target the true cause of choroidal neovascularization, because the true cause, as I've hypothesized with you, is choriocapillaris damage. And choriocapillaris damage leads to this ischemia and hypoxia, and that leads to the production of a molecule called hypoxia-inducible factor, which in turn leads to altered DNA expression in our cells, where we start producing a molecule that is called vascular endothelial growth factor. And it's vascular endothelial growth factor that our current therapy is targeted against. And that is what people have been getting injections of. Anti-VEGF agents, they've been getting injections in their eye for wet AMD probably since 2005 or 6, depending on whether they were enrolled in clinical trials or not. And it works really well. So it's imperfect, but it works very well. Now, in order to understand exactly why we do anti-VEGF therapy, and more importantly, what the new therapies are going to look like, I want to show you a little bit about blood vessel growth. So, blood vessels, capillaries, are basically comprising two cells. There's the endothelial cells that line the inner lumen, and then there's these cells on the outside called the pericytes that line the wall. And you need both of those cells in order to have blood vessels that both deliver blood and that don't leak fluid and that don't leak red blood cells, which is very bad. And when we have a condition of hypoxia, as I mentioned to you, the body starts making vascular endothelial growth factor, which induces a change in the structure of the capillaries. It causes the pericytes to go away, and the endothelial cells have receptors for VEGF, and they start growing out towards the VEGF in a process that's known as tip selection. And so you have some cells that end up being stalk cells, some cells that end up being tip cells. And this whole process matures into a situation called vessel sprouting. And the vessel sprouts eventually anastomose. And when things are going the way they're supposed to, you get a mature blood vessel. And the mature blood vessel doesn't happen, by magic. It happens because there's a change in the expression of certain chemicals of our cells, one of which is called angiopoietin-1, which causes the pericytes to become reestablished. And, we get this stable, mature vascular network. And that's like your finger healing from the cut. But the problem in age-related macular degeneration is that that's not what happens. What happens is we get the vascular endothelial growth factor production, which causes the immature blood vessels to grow. But what we don't get in most patients is the maturing part of the process where you have angiopoietin expression. And so these immature blood vessels leak blood and fluid. Okay. So now we can talk about the therapy and why we do it and how it works and how it doesn't work. So for wet AMD, there is treatment that blocks the effects of VEGF, and those are the standard injections that I'll mention. There's a sustained delivery system called the Port Delivery System that I'll illustrate, was recently approved by the FDA. And then there's gene therapy, which is not yet approved, but which looks pretty promising. And then for the combination therapy, we're combining, blocking modulating the angiopoietin system with the VEGF system. And that was just recently approved by the FDA. And then for the dry AMD, there's a delay, so forgive me for these pauses. There are complement inhibitors, one of which may be about to be approved by the FDA. And then there's cell-based therapy, which sounds very sexy, but I think doesn't work too well at this point. So for standard antivascular endothelial growth factor therapy, we've got bevacizumab or Avastin, and that's a full-length antibody, the two arms of which, and the two arms are this and this, the blue and the yellow, bind VEGF. There is ranibizumab or Lucentis, and this is actually a FAB fragment. It's just a fragment of an antibody that binds VEGF. And then there's aflibercept, or Eylea, as it's known commercially, which is a fusion protein. And these are the standard therapies for wet AMD, and they're injected into the eye. And just to give you a sense of how important these drugs are, in 2019, $13 billion Medicare spending, and projected to $22 billion in 2024. This is the first or second most important Medicare drug expenditure in the United States. Very important. And how we do it is illustrated here. First, you put a sterile lid speculum to keep the eyelids open, and you put in topical anesthesia. Then you sterilize the ocular surface with povidone iodine. And then you inject the material using a very thin needle going into the pars plana so you don't damage the retina. And this looks pretty cumbersome, but it's actually amazing how well it works. Truly amazing, which shows that you can't use logic very effectively when it comes to medicine. To give you an example, this is a patient, 63-year-old man. You can actually see the choroidal blood vessel in the fundus photograph. His vision was only mildly reduced to 20/40. If you look at his fluorescein angiogram, there's a hyperfluorescent area that if you look later on in the angiogram, you'll see that it increasingly fluoresces, and that fluorescence means it's, I'm going to go back a second, that fluorescence means it's leaking fluid, which is of course why he can't see. Fortunately, his other eye is totally normal with 20/20 vision and a normal angiogram. And if you look at the OCT, and this will illustrate how important the OCT is, you can see the fluid right there. And you know what? You'd never be able to see that clinically, never in a million years. Not the greatest retina person in the world could see that. But with this machine, anybody could see it. It's like a Paul Bunyan story. So following standard protocol, he gets the Lucentis injections, and not surprisingly, he does well. He comes back to 20/20, but then he gets a recurrence, which is very typical. He comes in with a little reduction in his vision. There's a little bit of fluid. He gets some more injections. Sorry for this delay. But he comes back to 20/20. And this, none of what I just showed you is so remarkable, although it's good news. Here's what's remarkable. That this person didn't need any more injections, at least not since I saw him last a few months ago, but here he is in 2015 with 20/20 vision. You can tell now, you're all experts at reading the OCT, there's no fluid. He looks fine. Very unusual to only require that many injections. What are the limitations of therapy? The first is efficacy. Let me show you what I mean by that. These plots are all plots of the same thing, but using different drugs. They're plots of visual improvement on the y-axis as a function of time on the x-axis. So this is the plot for Eylea, which shows about 9 letters of improvement over a year. This is the plot for Lucentis, which shows about 9 letters of improvement over a year. This is the plot for Avastin, which shows maybe 8 letters of improvement over a year. That sounds pretty good, but if you're a patient, you'd like it to be better. It's way better than the natural history. The second problem with the disease, with the treatments, is illustrated in this graph, which is again a plot of visual acuity change on the y-axis as a function of time on the x-axis. So if you start out at baseline, the patients have about 20/50 vision, and by 2 years later, they've got 20/70 vision, 20/40, even 20/30 vision, which is pretty good. You can do quite a bit with 20/30 vision. But by 5 years later, they're actually worse than when they presented. And you know, what were they going through during this time? Well, they were getting a lot of injections, 15 injections. And this is in the context of a randomized clinical trial. So you're looking at just about the best results you're ever going to see when you look at this. And my message to you is that most patients require many injections over many years to preserve their vision. And that raises the issue of durability. How long does each injection last? Why am I saying that's important? Well, that's illustrated by some data from Europe. And again, here we're looking at visual acuity change on the y-axis as a function of time. It doesn't matter which country you look at. You could look at the UK. Let's look at the UK, Netherlands, Germany, or rather France, Germany, Italy. Right off the bat, what you notice is that even at day 60, their visual improvement isn't as good as what's observed in the clinical studies. It ranges from 2 to 6 letters. Why? If you look at it 2 years, it's even more pathetic for all the countries: UK, Netherlands, France, Germany. Italy is really pathetic, and I'm Italian, so I'm saying that with some degree of shame. Well, here's the answer. Oop. Sorry about the way this works. Look at how many injections the patients got. They got only a fraction of the number of injections that they needed. And is it because they're lazy? Is it because they're stupid? Is it because they're poor? No. The logistics of getting injections is not trivial, especially if you're blind. How do you get to the doctor's office? So the durability issue is really a big deal. And that's why this was invented. It's called the port delivery system. Otherwise, it's commercially known as Susvimo. And it's just been approved by the FDA. The delivery system shown in that circle, it's essentially a flange device that you stick in the eye that's got a reservoir of material that's like ranibizumab. And here you can see it inside somebody's eye. And you can see the external view of it from the conjunctival surface. And when the port needs to be refilled, you just stick the needle into that external face, and that's basically how it works. How well does it work? Well, it turns out, that about 98% of the patients did need an injection more than every 6 months, which is a great improvement over current durability. In fact, if you look at the earlier phase 2 study, which was a pretty large study, 60% of the patients could go for 12 months with just one injection. So this is really, this sounds like magic, right? But it's not magic. First of all, you have to go to the operating room to get it. Secondly, there's a higher incidence of complications with this system compared to regular intravitreal injections. There's a 3-fold higher rate of infection in the eye, which is called endophthalmitis. And there are some complications that really just don't happen with the injections, like vitreous hemorrhage or implant dislocation or conjunctival erosion. Of course, retinal detachment pretty much never happens with these injections, but it does happen with this flange. Do patients like it? Yes, they like it. But it's early days, and where this is going to fit in is not clear. I'm sure it'll be useful for some patients, but I doubt that it'll be the standard thing for most patients. Then there's combination therapy. So just to remind you how this works, angiopoietin-1 is a cytokine that binds to a receptor called the Tie2 receptor. And by doing that, it creates a mature, stable vasculature. But under conditions of hypoxia, an angiogenic switch gets turned, and all of a sudden we start making a molecule called angiopoietin-2, which is a competitive inhibitor of Tie2. And as a result, angiopoietin-2 causes the vessels to become immature. And as you already know, vascular endothelial growth factor is produced in settings of hypoxia. And that stimulates uncontrolled and immature blood vessel growth. And so that's how you get this mess of choroidal neovascularization occurring. So what's the therapeutic idea? The therapeutic idea is to block VEGF and Ang2. And in so doing, to create a stable, mature blood vessel. So in other words, we leverage the body's response. We let the body make the abnormal blood vessel, but then we go in and make it become mature. That's the idea. And here's the molecule that allegedly can do this for us. It's faricimab, or Vabysmo. It was just approved by the FDA. It has one part of it that binds Ang2, one part of it that binds VEGF, and one part of it, which is the FC component, that's modified to make sure it stays inside the eye and doesn't elicit an inflammatory response. And you can see that in terms of the durability, about 45% of the patients needed an injection no more than every 4 months. In fact, this study wasn't designed to see if you could go beyond that. So some fraction of these patients almost certainly would have needed an injection even less frequently. About a third of the patients need an injection every 3 months, and about a fifth every 2 months. But 80% of the people getting injections every 3 to 4 months is a real movement in the right direction, and this stuff is injected into the eye. The real granddaddy of durability is gene therapy, and the way that would work is that you take a virus like the adeno-associated virus type A, and the capsid, which is the part of the virus that delivers its DNA into the target cell, well, you put in the DNA that's therapeutic, and that would be a gene that codes for a VEGF blocker. And then you inject this construct either into the subretinal space or into the suprachoroidal space. Now, and the idea is to infect the retina. Now, if you inject this stuff into the subretinal space, you're bringing the patient to the operating room. In my opinion, that's a non-starter. But if you inject it into the suprachoroidal space, you can do that in the office. And that could work. And this, you know, when your body's making the anti-VEGF protein, that's a sustained delivery. You know, you don't need multiple injections. Now, this is in an early phase of development, but the early data are showing what you would expect. So if you look at the control group, remember, these people are already getting anti-VEGF injections. So we're not expecting the output here to be better vision. We're expecting the output to be reduced injection frequency. So if you look at the people who are the control group who are getting monthly anti-VEGF injections, their vision, which is on the y-axis, is stable over time, which is on the x-axis, but they take 7 injections to do that. Whereas the people that get gene therapy, and there were 2 different doses, they get that with just 1 injection. So this could really attack the durability problem. It's too soon to say what the long-term effects will be, though. In terms of geographic atrophy, I haven't explained this, but now I'm going to explain it. Typically, geographic atrophy does not start in the fovea. It starts outside the fovea, and then over time, it gradually wraps its way around the fovea and then involves the fovea. And as it does that, the vision goes down. And this process, from the start of extrafoveal atrophy to foveal atrophy, takes on average about 2.5 years. Well, what are we going to do about that? Well, if you think about designing a therapy for this, when you want to do the therapy is when the atrophy has not yet involved the fovea. If you wait for the advanced stages of the disease, you're not going to preserve vision because the photoreceptors are already dead. Now, why this might work is the following, and this is a slide I just added, so forgive me if this seems very boring to you, but I thought some of you might find it interesting. So it turns out that complement factor 5A binds to a receptor on a cell, and that initiates a process that's known as signal priming, and that leads to the expression of a molecule called NF-kappa B, which changes DNA expression so that it starts to produce NLRP3 and interleukin 1 beta and 18. And if there's a second signal, and it could be mitochondrial damage from oxidative damage, it could be factor C3A binding to a surface receptor, these solubilized materials actually become assembled, and that creates signal number 2, which drives the assembly of these NRLP3 caspase and ASC into what's known as the inflammasome. It's actually the NRLP3 inflammasome. And this thing, this macromolecular complex, activates an enzyme that cleaves these interleukins and creates a very bad inflammatory response called pyroptosis, which kills the cells. And that is why we use complement inhibitors to stop geographic atrophy. I've shown you from genetics, from laboratory studies that I haven't shown you, and from postmortem histology that complement's important in developing AMD. And you also know from what I've said that activation of complement leads to the formation of C3A and C3B and C5A and C5B. And now you know in some detail that C3a and C5a activate the inflammasome, which causes death, and C5b creates that pore, which causes the cells to die. And that's why we're looking at C3 and C5 inhibitors to treat geographic atrophy. And one of them is called avacincaptad. It's an RNA molecule. It's injected into the eye. And here you can see the results. If you look on a y-axis at the size of geographic atrophy as a function of time on the x-axis, the solid line shows the rate of growth, right? That's the first derivative of the treated patients versus the untreated patients, which is the dotted line. It's a 27% reduction, which is very significant. That's from a phase 2 study. This is a different molecule that blocks C3. It's called pegcetacoplan. It produces pretty similar reduction in the rate of growth of atrophy. Pegcetacoplan right now is before the FDA for treatment of geographic atrophy. I suspect it will be approved. There's another thing that happens in AMD that I haven't mentioned, but I just want to touch on, which is the accumulation of amyloid oligomers. As you all probably know, amyloid is a component of Alzheimer's disease, but it's also a component of AMD. And amyloid oligomers, which are shown here in green, accumulate in drusen. And it turns out, and you can stain substances that drive the formation of these oligomers in an animal model of macular degeneration. Outside the degeneration, there are none of these things. Inside, there's a ton of them, all labeled red. Well, you can block the formation of these things with a class of reverse transcriptase inhibitors called camulidines. You probably have heard of reverse transcriptase inhibitors as a treatment for AIDS, but it turns out you can have these molecules that are not retrovirally active, but that do block this phenomenon. So this is another treatment in development. And I don't want to close without mentioning cell-based therapy, mostly to tell you to be cautious of it. This is an experiment that was done very, very carefully by Dr. Steve Schwartz at UCLA using the suspension of stem cell-derived RPE cells in a patient with geographic atrophy. That black circle shows the planned area of the transplant, and the red circle at 3 months shows you where the transplant was done. You can recognize them because they're pigmented cells, and there's the pigmented cells at 6 months. Unfortunately, the visual improvement in these patients was minimal. The survival of the RPE cells in the area of atrophy was minimal. But there's a different way to transplant the cells, and that's using a scaffold. And this work was done by Dr. Mark Ryan at USC with his colleagues at Caltech. They used a substance called Parylene C, which is biocompatible. They nano-engineered it so that it's a mesh with the thickest part being 6 microns thick and the thinnest part being 0.3 microns thick. And these 0.3 micron thick areas were conceived of as diffusion zones to allow nutrients to exchange between the choriocapillaris and the retina. And they comprise about 58% of the surface area of the scaffold. You can see one of these RPE covered scaffolds in panel A, and if you look under high magnification, you can see that these cells are cuboidal and they're pigmented. And here you see a picture of a patient with geographic atrophy. Before treatment, they could see 7 letters. After treatment, the scaffolds in that, right under that area, they see 24 letters. This is a great result. It's not typical. This is still a thing early in development. One idea, which is a little bit not surprising to you based on what I've said, is maybe the thing we should be doing is growing blood vessels for patients with AMD. But the thing is to grow them so that they're mature. And that's a whole different idea about how to do treatment, and one that I'm not going to talk about at all, but one that's probably obvious to you based on what I've said. So how do we approach the patient? This just takes a minute. And naturally, we want to know if they smoke. Why is that? Because of all the reversible risk factors, the only one that really matters is your smoking history. If you smoke, you increase your risk of AMD by factor 2. If you stop smoking, your risk goes down. Now, there are some medications that probably wouldn't be great to be using if you have drusen. For example, Plaquenil, if you have rheumatoid arthritis or systemic lupus erythematosus. And if we could, we'd try to get you off that medicine. The family history might be relevant because if you've got an early onset AMD family history, you might want to start vitamin and mineral replacement earlier than normal. Of course, we fully examine the eye. But the real bottom line here is the testing, and most important test is the OCT, occasionally the fluorescein angiogram. Some people advocate genetic testing. I don't. The reason they advocate it is they think that it actually increases your risk for progression depending on what your complement mutations are. That's a very controversial position. There might be some additional tests that I haven't mentioned if there's some uncertainty about the diagnosis. The treatments I've gone through, the only one I haven't told you about is the minimal replacement. I just want to mention it briefly. First of all, it doesn't do any good if you have early AMD. It only seems to be beneficial if you have intermediate AMD. Your doctor is going to be able to tell you if you have early versus intermediate. And secondly, we like it because it reduces the risk of motor visual loss by about 19% during a 5-year period of follow-up. But it doesn't reduce your risk of developing atrophy. It only reduces your risk of developing choroidal neovascularization. The last point about cell therapy that I want to mention that I haven't mentioned is the real promise of it, in my opinion, is not site restoration, site preservation. It's site restoration, and that's a few years off. Anyway, sorry for going over a little bit, but I do appreciate the privilege of being here and speaking to you, and I thank you for your attention.
I guess I'm just supposed to handle the Q&A here, and there are people online. If you'd raise your hands. If there are people in the room who want to ask a question, if you come up here, because you're going to have to ask the question here so that everybody can hear it. So come on up if you want.
Thank you. An extremely impressive presentation. I'm here because my wife has the onset of macular degeneration. And what she's been told at the moment is the only thing that they can do for her is Persevision vitamins. But that things are coming and it won't be long. We may have some better options. You went through a whole bunch of options, but I don't know which ones are available or imminent. And I guess that's the question. What can she expect as her degeneration has been very slow, but is beginning to, I think, get worse. Thank you very much for what you've done. And if I ever get it, I want you to be my doctor.
I tell you what, it doesn't matter who your doctor is, it's the medicine that works. It's hard to give advice regarding your wife that's precise, but my intuition is that she's getting worse. Otherwise, she wouldn't be asking what else could be done. And generally, the way people get worse is one of two ways. They get atrophy or they get the abnormal blood vessels. I'm guessing that she's got the atrophy because there's already an established therapy for the white blood vessels. And the way you phrased what the doctor said, he wouldn't have said it or she wouldn't have said it that way. So what's coming down the pike for people that are getting progressive atrophy is the complement inhibitors. And the thing I didn't go into for lack of time is that, when phase 3 studies are done, the FDA is, the FDA gets a bad rap, but it's an incredibly good organization. It's remarkably good considering how underfunded it is. And so they suggest things. And one of the things they suggest is 2 clinical trials. So whenever you're doing a registration clinical trial, you're going to run 2 clinical trials simultaneously. Well, one of the clinical trials for the pegcetacoplan gave a positive result, just like the phase 2 study did. One of them didn't. But what they'll typically do, and this has happened before, this isn't like the first time it happened, is they combine the data from both studies and see if the results are still significant, and they were. And that makes me think that the FDA is likely to approve, it's just a speculation, but they're likely to approve the pegcetacoplan, particularly because there's no other therapy available for the advanced form of dry AMD. So I think that's what the doctor was probably referring to. Well, the FDA has had it before them for a few months now. So I would be surprised if we don't know by Christmas whether they're going to approve it or not.
Thank you.
We have a question online. Alejo?
Please go ahead.
Dr. Zarbin, thank you for an awesomely informative talk. The medical profession has created artificial limbs like arms and legs that can be attached to the human body and controlled by nerve impulses. Do you think in the not too distant future, is there any hope of similarly creating artificial eyes to replace diseased eyes?
Believe it or not, I was on a DoD panel. The short answer is not in my lifetime, but I was on a DoD panel where someone proposed exactly that. And it wasn't crazy. There are a couple of problems that are really big, and that doesn't mean they're unsolvable. It's just they're big. One of them is vascular anastomosis, which you don't need to know much anatomy to realize that's a big deal. That's actually the most solvable problem. The hardest problem is the optic nerve. There are about 1.1 million axons comprising the optic nerve. And you've got to, and it's worse than that. It's that those axons all go to different places. And how do they get to the right place? It's through a process. It's sort of like, how did someone get into MIT? I mean, there are a lot of people that applied to MIT. How did they get in? Well, that sort of selection process is what determines where those axons end up. And you got to get that right a lot in order to achieve that. But there are some early attempts to do what you're saying. And I didn't mention them because they weren't relevant to this disease. But for example, Mark Hamayan developed a electrical prosthesis, the purpose of which is to replace the photoreceptors, and others have too. And the problem, and the reason that can work is that while the photoreceptors die, the rest of the retina is more or less intact. But the thing we have to realize is the retina is not like a circuit board. Okay, if you take out the diode of the circuit board and you put in another diode, you're good. That's not the retina. When you take out a cell from the retina, it rewires itself because it always wants to hear the music. Think of it that way. So you've got to manage the rewiring process when you take that approach to sight restoration. But just to show you how cool the things coming down the pike are, another thing you could do would be to take a cell that's not light sensing and infect it with molecules that are light sensitive ion channels and turn them into the photoreceptors. And that's been done. It's been done and published at the level of the ganglion cells, and it's been done and published even better at the level of the bipolar cells, where the image processing tends to begin. So that's a very clever way of bending Mother Nature's will, if you will. But the most brilliant way is to work with Mother Nature, and that is to regenerate the retina. And that actually happens in salamanders, it happens in zebrafish, and as you can imagine, that fact hasn't escaped the attention of the scientific community. And so it turns out that under certain conditions, you can take Mueller cells, which are one of the glial cells of the retina, and given the right set of circumstances, you can induce them to differentiate into ganglion cells, which could be a treatment for glaucoma, or to photoreceptors, which could be a treatment for a number of diseases, among which is age-related macular degeneration. That most subtle, that's kind of closest to the creator level of manipulating biology, is something that is in full force right now. And I will not be surprised if, assuming I have a normal lifespan, if that's actually something that happens in medicine over the next 30 years, something like that.
Thank you.
Are there any other questions in the room? Are there any other questions online?
Yep, Bill Tittle.
Bill Tittle.
Yes, thank you very much. A fascinating talk. My wife's father went blind with AMD. Does that increase her chances of getting it? And how does she, can she just be tested for AMD?
It probably does increase her risk of developing it as she gets older. But we need to know a little bit more about her dad. For example, did he smoke a lot?
Yes.
Yeah, so you see that, so you can, it's like anything else. You can have, like I think I have ADD, but I figured out through a miracle, how to deal with it. So you can inherit something and do fine with it. So she may have inherited that tendency, but if she doesn't smoke,
Yeah.
maybe she won't get anything. The answer to your second question is, you'd have to undergo an eye exam, a dilated fundus exam, preferably by probably a general ophthalmologist would be fine, but a retina specialist if you really want to be sure you're nailing it down.
Okay, thanks very much.
Are there any other questions online?
Herb Waddell.
Yes, hi. Somewhere along the line, I got the notion that macular degeneration develops relatively young. Now I'm 94, so that means below 90. And that if you reach age, your chances of suffering from macular degeneration decline. Is that so, or is that just a wishful thought on my part?
It's a wishful thought, but you can keep having it. So the problem is the phrase macular degeneration, which is a very imprecise phrase. The disease, the macula, as you now know, is just a location. It's not a disease. But people use the phrase macular degeneration to refer to a disease, and usually the disease to which they're referring is age-related macular degeneration. But the most common cause of macular degeneration in children is Stargardt disease, totally different disease. Okay, so it could be that you got the idea that it happens early because you knew or know someone who had one of those childhood macular dystrophies, and they got that disease early. In terms of your risk of getting it, if you don't have it now, the probability of you getting it it's as close to zero as you can calculate a probability in biology.
Thank you.
You have one more.
Best news all day.
Roger Burns.
One final question.
Yes, doctor, thank you for scheduling your talk on the same day that I'm going for a shot. I have a 2 o'clock appointment today for my sixth eye injection. I do take the Preservision, and you mentioned something about taking, I guess, additional vitamins early on. My wife is an advocate of nutrients, and she asked me to ask you about your opinion of lutein. She wants me to take 40 milligrams a day. I did ask my macular doctor about that, and he said, well, if it makes her happy, do it. So what's your thought on that? And one more question. What are the odds of this going into my other eye?
It's about the answer to the second question first. It's at least 50% during the next 5 years, I would say. Depending on what your actual involved eye looks like now, the risk could be even higher, actually. But that's okay. You've got effective therapy, and you're probably going to show up on time for all your appointments, and that makes a big difference, believe it or not. As far as your wife is concerned, so this is a very common, if I may call it a problem, and it really is a problem. So people think that if 1 milligram is good, then 10 milligrams is 10 times as good, And that is not how biology works at all. And I'm not talking philosophy, I'm talking data. So if we look at growth factors, they typically have a bell-shaped curve in terms of their effects. So you've got to hit the sweet spot. And I'll give you a very simple example. If you have a vitamin A deficiency, you will go blind. If you take too much vitamin A, you will go blind. So vitamin A deficiency in the third world, Arctic explorers with the vitamin A excess by eating polar bear livers, all documented. So the way to be, in my opinion, when you're talking about medicine, is to be empirical. And the only empirical data that I think are of the highest level of integrity clinically are the phase 3 clinical trial data. And the phase 3 clinical trial data with the AREDS2 supplement, if you look at the bottom, will show you that it does have lutein in it. Would more lutein be better? We could talk about it, but that's like talking about Gödel's incompleteness theorem or something. It's, it gets into philosophy. It's not medicine. And and I could give you many examples. I'll give you one example. The administration of oxygen to premature babies went big in the 40s, and it saved a lot of lives. And around that time, there was a big incidence of blindness in those children. And one of my teachers, Dr. Arnold Patz, concluded that it was the oxygen that was causing the blindness. So he proposed a study where he was going to restrict the oxygen exposure to some of the children and not the others. He didn't just get his grant proposal rejected. Right now, he would be in the New York Times for an ethical proposal, but his brother funded the study because his brother was a successful businessman. And it turned out that he was right. The oxygen exposure was what caused the problem. So you see, thinking is not the same as knowing, right? And so your wife thinks that 40 is good, but that's not the same as knowing that it's good. Now, there's another problem, which is that there are data that show that lutein and zeaxanthin supplementation improve visual acuity and visual contrast sensitivity in older people. That's not the same as talking about treating age-related macular degeneration. Those are two different problems. But you could see how easily people would get those two things confused.
Sure. Well, thank you. Appreciate your time.
Sure.
Well, Dr. Marco Zarbin, rather, we have two ways of saying thank you. One is we'd like to present you with a certificate from the old guard of our appreciation. You will notice on it there is an orchid. And the orchid in 1930, when this society was founded, was one of the orchid capitals in the United States. And so we use that as our symbol. The second way we have of saying thank you is a standing ovation.